And then last week we talked about testing changes. So how do we use PDSA cycles? What's in a PDSA cycle? How do we scale them up, and when are we ready to implement? Just a reminder that we are going to be recording this session, and that will be available to share with your colleagues, or if there's someone that you know from your team that's missed it, you can share that with them as well. So I noticed a few people have already started with this. If you wouldn't mind, in the chat box, add your name and your organization. If there's anyone else in the room with you, if you could throw that into the chat box too, that'd be super helpful. Okay, and so learning objectives for today, just like we did last time, we're going to do a bit of a review from the last session, resolve any questions, and then I'm going to be really keen to hear from everyone about PDSA cycles that have been tested over the last week. 2 is to describe the important functions of leadership, project management, and change management in our quality improvement projects. And 3 is to identify strategies to manage the human dimensions of change. So that's what we're going to cover today in the last session. So beginning with a review of last week, you'll recall we really talked quite a bit about the Plan, Do, Study, Act cycle, or PDSA cycle. It's a structured approach to quickly test, adapt, and implement changes. We talked about the components of a Plan, Do, Study, Act cycle and why they're important. So starting with an objective, questions, and predictions, your concrete plan for carrying out the test to change who, what, where, when, carrying it out, studying the results, and then acting based on what you learn. And we also shared in the follow-up email, as well as the pre-email to that session, a template for PDSA cycle so that you can follow those steps as you do it. We talked about some basic principles for testing changes, starting really small. If this is our first test to change and we don't have a high degree of belief that it's going to work, we maybe don't have organizational or staff commitment for the change, and we're not totally, we really want to manage the risk. We're not sure what risks might be inherent in the change. We want to start really small. As we begin to start our small scale tests of change, we're going to be building knowledge with each of the tests. We're going to scale those tests up over time, testing over a wide range of conditions. And recall when we talked about ranges of conditions, it could be things like time of day or seasons, whether it's a weekend or a weekday. If it works internally with our staff, does it work across our organizational boundaries? Does it work with staff of different skills and experience levels? So that's how we test over a wide range of conditions. And then finally, when we're ready, so we have a high degree of belief in the change that it's going to lead to an improvement. We're pretty sure we've tested over a pretty robust number of conditions. Then we're ready to implement it, to make it permanent within the organization. And we talked about a number of things you can do: training, documentation, communication, to really embed that change into the organizational fabric. So I just want to pause and see if there's any questions that came up for you from last week.
This is Sean. I'm just curious for everyone on the phone, what's been the toughest thing you've had to deal with in your organization with the changes you've been trying to make?
Okay, sounds good.
Ray, I'm going to pick on you. I know you're on mute, but you're always up for talking.
Thanks, John. I think the most difficult is getting clean data, and what I'm encouraged by Christina's help was that sometimes like good enough data is enough to paint the picture and not perfect data. And so maybe I've been just focusing too much on perfect data. And so I don't know if that answers your question, John.
Yeah.
And Ray, just to sort of sort of emphasize what you said, it becomes really easier to see how imperfect data is just fine the longer we begin to collect it, because as long as we're collecting it the same way each time, it has sort of that validity or fidelity to the method of collection. And so that always remains true. And what we can then see is the noise or the variation in the system emerging. So we don't need that perfect data, but we do need the data over time, and that tells us a whole lot about the system. Okay, I'm hopeful that a few people have been able to do a PDSA cycle over the last week. So has anyone had an opportunity to do a test of change?
I'll just keep picking on people. I see North Valley and Rhonda's group. Have you guys had a chance to go through it? You guys show your pictures so I can see you. I saw you laugh when I said that.
Yeah. Sorry, we were conferencing about which PDSA we wanted to talk about. Recently, we've been doing a lot of PDSA work on hygiene over on our acute care floor. And so we noticed that we were lacking some documentation as far as, they were really good about documenting some sort of hygiene care every day, but we didn't feel like the documentation was complete. So we did a PDSA cycle, and we shared the data with them, and we continue the cycle. And when we see improvements, we communicate that, and when we identify other areas that need improvement, we communicate that and just start the cycle all over again. And we have noticed an improvement in our hygiene care provided and documented.
Awesome. What was one of the changes that you tested to improve the completion of documentation and hand hygiene?
Well, it wasn't necessarily hand hygiene, it was hygiene care provided to our patients.
Oh, hygiene care. Okay, yeah.
And we raised the bar on our expectation as far as what we wanted to see documented. So we believed that they were doing the work, but we felt like our staff had gotten lax on their documentation, whatever they were documenting. And so we brought that to their attention, and we told them we will be auditing this. We are looking for this. And we noticed that the documentation started improving, and we felt like it was a better reflection of the care our patients were receiving. So we'll provide a little more real-time feedback, and
is there any
support?
That's great. So you're sharing the data with them, and they're able to see it as one of the tests of change?
Yeah.
Cool. Thanks for sharing.
You're welcome.
Anyone else, tests of change that you've completed, or maybe a change that you're thinking about testing over the next week or so?
Hi, this is Kelly from QI Medical Center.
Hey, Kelly.
So although we are doing a PDSA, it doesn't necessarily have anything specific to do with any of the TCM type stuff or whatever, but we have joined the ACO and we're working on annual wellness visits. And so we have been meeting every couple of weeks or so and updating this PDSA on, how to get people in the door, advertising, and then coming back to it again and seeing what worked and what didn't, and just kind of going through this process of getting it up and running so that it's a program that our patients know is here all the time. So it's been challenging, but we just keep trying to plug away with it. And obviously these are revolving. They don't ever really seem to stop, because, we figure out a good way to do something and come back to the drawing board, and just kind of keep going with it. So we're trying here.
Sounds like you have a lot of changes embedded in there, Kelly. So that's really great, because often to change a system or to build awareness for a program, you need to pursue a whole bunch of different changes in the system to achieve that goal. So I'm curious, some of the changes I heard are getting people in the door, so maybe engaging them. You're working on communications and marketing, building that awareness. Is there anything you can break down, do you think, into a small test of change?
I am not really sure at this time. I think the whole thought of, getting, 1,000+ people in the door for a wellness visit can be overwhelming. And so we really haven't broken it down into smaller pieces and working on smaller pieces as we go. We just meet and talk about the whole monstrosity of it. And, and maybe that would be something better next time we meet, is to really just sit down and go through the little pieces of each one, and let's, try the little piece and then move on to the next little piece.
Mm-hmm. Yeah, sometimes that helps in breaking down and managing what seems like really overwhelming big changes. I've heard a lot of really good things in what you're doing. So if you're trying to increase engagement or attendance, show up rate to wellness visits, that sounds like it's probably your aim and something that's really measurable. We didn't talk a lot about creating driver diagrams, but that's basically just your change package. Are you familiar with using a driver diagram or logic model or something like that?
No.
Okay, so a driver diagram really just breaks down all the change ideas you have that align up to your aim. So if your aim is to increase wellness visits, the number of patients presenting for wellness visits, some of the changes, the big bucket things, you can break up into a driver diagram. And you can Google driver diagram, lots will come up. It gives you a good sense of what it is. You can also connect with me, and I can share some ideas too. In your driver diagram, you'd have some big buckets like communication and marketing. You'd also have engagement with patients. So within that might be making it a welcoming environment. So each time you create a bucket or change concept, you can break that down further into some of the discrete things that you think you can do, and those are your testable change ideas. So a testable change idea in this case, if you want to make it a welcoming environment, every patient is greeted with a hello or something warm like that. And so that's very testable. You can measure that at a PDSA level, asking patients, were you greeted with a hello? Or were you greeted with an introduction, something like that. So that's how you can kind of break it down. And over time, you're measuring the bigger project level measures of number of people attending wellness visits. Is that helpful?
Super, thank you. Yeah.
Okay, good. Anyone else, changes you're thinking about testing or changes you already have tested?
This is Alex at CBH.
Hey, Alex.
I haven't had a chance to test anything specifically yet, but one thing that I do really want to test is increasing the follow-up appointments that we're making.
Mm-hmm.
And I, after listening last week, I think the ticket is to kind of cut back a little bit and maybe pick one diagnosis that needs to be called on and try to get that habit in our nurses, ER nurses, mind and care planning, I guess, so that it can, then we can branch out into more diagnoses, because right now it's just very sporadic and tends to only happen if the doctor himself asks them to do it.
Mm-hmm.
So I think if we just scale it back a bit and start small and then gradually build up, I think that would really get us some more results.
Yeah, and that comes straight back to that first principle in PDSA cycles or testing changes, which is to start really small. So if you're doing follow-up appointments, just do one 1 week and see what you learn. Some of the things that you can consider when you're designing a PDSA cycle are to think about it from the perspective of a fundamental change for the system. One of the things that Dr. W. Edwards Deming, who we talked about way back at the first session, who was sort of the guru and lead thinker on all of this stuff, was he said, cease reliance on audit and inspection as your tool to get things done. So if all you're doing is audit and inspection, that's good for a temporary change in behavior, but might not provide that sustainable system shift that you're looking for over time. So if you think about that as you're designing what your test of change will be, you can start thinking about, if you're finding things like the follow-up appointment only occurs when a physician reminds a person to do so, then how can we build that decision support or that reminder into the change, and thinking about it from that sort of fundamental system level.
Awesome, thank you.
Yeah, hopefully that's helpful. Again, just go back to the principles of starting really small, especially if you're new to PDSA cycles or maybe you're really familiar with them. This is something I always have to remind myself of. It gets really easy to get really big. It gets really easy to sort of lose the discipline for doing a PDSA cycle, and you just don't get as much learning out of it. So my recommendation for everyone is to, especially with new projects, to be a little disciplined in the early stages of documenting your PDSA cycles, doing it together as a team, and to be really clear about what are we testing, what is the specific change, and what is our prediction. So be really disciplined about that, make it really small, and do a few test cycles to get you going, and start before you're ready. So you might be thinking, we have to plan, we have to work at a few more things first. But if you start testing right away, you're gonna drive learning really quickly. So getting going early is a really good strategy. Okay, well, thank you everyone for sharing what you're planning to do or what you've already done with some of your tests of change. I'm sure John will be in touch over the course of the project to learn more about some of the tests you're changing, or the changes you're testing, I should say. It's always awesome to be able to come together and share that as a group too. That's a great way to spread some of the learning that's happening. So I'm going to shift gears now and talk about the improvement process. So we've talked a lot about the technical details of quality improvement, how you might do it. What we haven't really talked about is quality improvement as a project or as a process. So I'm going to focus on 3 key points to keep it simple today. The first is all improvement projects need leadership or sponsorship, project management, and change management. So we're going to talk a little bit about each of these concepts. I've got this quote on leadership that there's solid evidence that leadership engagement and focus drives improvements in healthcare quality and reduces patient harm. I think this is probably pretty intuitive for almost everyone, that the stronger the leadership support we have, the more likely we are to succeed. It becomes most obvious when we feel like we don't have that leadership support, and it becomes very difficult to be effective in our role, especially as it relates to change and improvement. So I've got a nice little framework here that the Institute for Healthcare Improvement has developed. It's called High Impact Leadership to Improve Care, Improve the Health of Populations, and Reduce Costs. So that's the triple aim. And there's a couple different domains in the high impact leadership behaviors framework. The first one is to become person-centered. So a leader that is consistently person-centered in both word and deed. The second is to engage with frontline staff. So be a regular, authentic presence at the front line and a visible champion of improvement. That's what we're hoping for in leadership. Third is to have a relentless focus. Remain focused on the vision and the strategy. And in our case, the aim, our charter includes the aim of what we're trying to do and how that aim aligns with the organizational vision and strategy. Fourth is transparency. Require transparency about results, progress, aims, defects. This is something like sharing our improvement data. Of course, it's aggregate. It doesn't have patient identifiers. So sharing our improvement data with patients, with staff, being transparent about it. Sharing what our gaps are. What are our quality gaps that we're trying to close, and what are our aims? And then finally, the last high impact leadership behavior is to become boundarylessness. That word just kills me. I don't even know if it is a word, but it's in there. So to overcome the boundaries in our systems, and to encourage and practice systems thinking and collaboration across boundaries. And when I think about boundaries, I think about both professional boundaries. We have our professional identities like administration or physicians, patients, social workers, nurses. So all of these have their own professional identities and boundaries. We have internal organizational boundaries. So different departments like our emergency department, our ICUs, finance, information systems. And then we have external organizational boundaries, like we have hospitals, primary care, first responders, community support agencies. So these are all examples of boundaries that we encounter in our work, and how can we bridge those boundaries as leaders? What's nice about these high impact leadership behaviors in this framework is that it's really universal. So it applies to us not only as members of an improvement team, but it applies also to the leaders that we work with, who are our bosses or our directors or sponsors of our improvement projects. And it helps to think about each of these elements as we're thinking about how can we also support our sponsors and our leaders to effectively lead our projects. One of the things I've found consistently in the improvement projects I've worked on is that leaders often look to the people who are doing the improvement to support them as well, to be effective leaders for them. And we're all incredibly busy. We all have a lot of distractions. And so sometimes this is one of the things that gets neglected, because we just don't think about it, or we just don't have the time to do it. But there's a few simple things that we can probably be doing within each of these domains to help our leaders become more engaged in our project. So just thinking about that as a question, and I'm going to come back to the framework. What are some of the things you think that we can help our leaders do as it relates to becoming person-centered? What do you guys think we can do as improvers?
One of the things I think we can do is to share with the frontline staff how everything that they do impacts the change we're trying to make. Because I think they need an understanding of why we're doing this change, and the whole goal of what we're doing. And if they understand that, you get more buy-in.
That's a good point, and actually not the perspective that I was thinking from, but it's a really, really well put and well taken, that we need to understand the staff. So thinking about person-centered broadly in terms of who's going to be affected by the change, and what do we understand about their needs around that change. Thanks. Anyone else? Person-centered. How can we help leaders become person-centered?
This is Ray. I think when I read this, I think of like a balance measure.
Mhm.
Is our change, how's it affecting the person or persons? And it can either be the staff or for the patient himself.
Mhm.
And so I think like this is like a balance measure. Like, are we actually making things better, or just more efficient for us and worse for the patient?
Mhm. Yeah, great. Thanks, Ray. So helping our leaders become person-centered, some of the things I can think of too is sharing patient stories. So if there's examples of impact to patient, sharing that with our leaders so they see the effects of our changes. Also to share patient stories that are bad, that illustrate the care quality gap that we have, the impetus for change that lends support to the business case for doing the work that we're doing. What about frontline engagement? How can we support our leaders to engage with the frontline, to be visible champions of improvement?
This is John. I'm curious for everyone who's going through these changes. How often do you guys go and look to see how these process improvement efforts are going with the patient, or walk through a step with your frontline staff to get their feedback in the moment?
This is Ray. I do it first. I guess I see if the plan actually is working. Is it actually achieving what I thought I would achieve? Walking through it first.
Thanks, Ray. Anyone else? So for frontline engagement, some of the things, I think about that same thing, Ray. That's a great idea, an example. As leaders, we can show up at improvement team meetings. We can be interested, ask about data. Likewise, if we're improvement team members, we can invite our leaders to those meetings, invite them to take a look at data, share presentations we might have, invite them to do a PDSA along with us, or engage with the staff as they do a PDSA. So that's a great way to show it doesn't take a lot of time and you just attend a periodic meeting, but a great way to show that visible leadership and champion improvement. What about relentless focus? What do you guys think? Remain focused on the vision and strategy.
I'm just going to pick on people. So I'm going to ask Cooley Medical Center. Kelly, do you guys have any thoughts over there? Kelly and Molly?
We have this on.
Well,
How have you guys
Remain focused on vision and
how have you
strategy.
guys narrowed your focus or worked on focus in regards to some of the projects? I know you guys even, you have said multiple times that you've actually really focused your TCM project more and more as you go through this process.
well, now, yes,
I think we're focused more for that program because we have somebody that's keeping all of us, the group, that's keeping track of all the meetings, keeping track of the due dates and those kinds of things. So you have somebody that's kind of poking at you with it so that you stay on task. And I feel like that's really important for these types of projects because we all have so many hats in a rural location like this, where we're working 3 different positions, and it's hard to keep up and keep track of that. So you almost need somebody that's constantly sending you those calendar invites and things.
Mm-hmm. Yeah, and part of that is the project management, which I think is so important to stay focused and stay on track. In terms of remaining focused on the vision and strategy, ensuring that it's aligned with the our aims, our project charters, our improvement charters are aligned with the organizational vision and strategy. At the top of every improvement team meeting, taking a look at what is our aim, what are we here to accomplish, and reminding ourselves of that each time. Sharing that widely as well really helps us become purposeful and focused on what we're trying to achieve. When it comes to transparency, a few ideas are to share storyboards within the organization, to share the improvement data that you're collecting over time. If you are the leader of an improvement project, to be asking your team, what's your data this month? What is your data telling you over time? What are you learning from your PDSA cycles? If you're a member of a team, to offer some of that information to your leadership. Here's what we know over the last few months about our system. Here's what we've learned. Here's some of our PDSA cycles. And sharing that in concise little bits of information can be really helpful to leaders to engage and to be present for us and support us. When it comes to breaking down boundaries, how do we work across systems? What are some things that you guys are doing?
Can I ask, for those who have worked across other organizations, or just even from acute care to your primary care department, what are some things you guys have done to make those connections?
This is Alex at CBH. I think it really just comes down to communication and being persistent.
Mm-hmm.
Some people may not willingly keep those lines open, but if you keep calling or emailing or just getting in touch with them, it really opens up those boundaries by just communicating in general.
Mm-hmm. Yeah, thanks, Alex. I think, communication is paramount, and persistence probably too. Again, we're busy, right? And we've all got distractions. So creating relationships, constantly communicating, setting up meetings to meet people outside of your organization or within other departments, inviting other departments and professions, being deliberate about making sure you have diversity on your improvement team can also be really important to break down those boundaries. Thanks so much, guys, for sharing. Leadership is probably felt to be really important by all of us. And so just reminding ourselves in terms of strategies, there are things we can do as leaders, and there's also things we can do to support our leaders. And we need to be doing both if we want to ensure the success of our improvement projects. I'm going to talk a little bit about project management. This is going to be super high level. You guys are already right into your projects and probably potentially have internal methods for managing projects. But it's sometimes easy to forget that a quality improvement project is a project, and it does need to be managed as any other does. And so project management here is, we talk about it being the practice of initiating, planning, executing, controlling, and closing the work of a team to achieve specific goals and meet specific success criteria at the specified time. So just really simply, here's a common project management framework. It starts at initiation, planning, execution, monitoring, and close. And if we make this specific to an improvement project, we can think about a few different elements in each of these steps. So the first, when we're starting or initiating a project, we want to think about our business case. We might do some root cause analysis or understanding the care quality gap. Why does it exist? That's part of the problem definition as well. Looking for different change ideas. What's best practice? What are the leading practice? What do experts know about this care quality gap? And then engaging leaders at the start of the project. When it comes to planning for our improvement projects, we create our charter with our aims, measures, and change ideas. We also think about establishing that diverse improvement team. We think about setting up meeting schedules, timelines for how we're going to get and when we're going to get the work done, setting up measurement systems, and setting up how we're going to document our project. So where will the charter live? Where will we track our PDSA cycles and our ramps of PDSA cycles over time? In the middle of the project, where is the execution phase, that's really when we're testing our changes. We're using PDSA cycles, we're scaling them up over time. Lots of communication happens within our team, across our team, to other staff and to leadership. And we're carrying out the plans that we've set in our charter. Monitoring really speaks to that measurement over time, to be checking back against our charter and our aim statement. Are we getting closer? And the budget and our timelines as well, being cognizant of where we're at with those. And finally, when it comes to close, this is where we think about documenting our improvement project, finalizing any implementation steps from our changes, and creating a plan or assigning an owner for the sustainability. When it comes to quality improvement projects, we will have measured over time, and we've got our aim. And so what we're looking at is to achieve our aim as indicated by our measures. So we've reached our target on our measures. That's fantastic. Once we've finished up with all the implementation steps, then we're probably ready to close. But when it comes to closing a quality improvement project, we don't want to take our foot off the gas entirely, because we risk the sustainability of the changes we're putting in place. So typically with something like this, we'll want to continue to measure it, and someone will be assigned that role, that sustainability role. We'll want to continue to measure it, but just less frequently, so that we can see if any of our progress is sliding back to previous performance. So there's just a bunch of those things summarized: business case, improvement team, project charter. And this isn't a linear sequence of events. Some of these happen at different stages. Some of them get reorganized at different stages. But thinking about some of the discrete planning steps that we need to put in place for our improvement projects can be really helpful. The last element I want to talk about as we think about quality improvement as an improvement process is change management. And this is a fairly large body of knowledge, but I'm going to break it down into hopefully what will be a bit of a simple sort of an analogy. But what change management is, or how I'm referring to it, is that it's a structured approach to prepare, support, and help individuals, teams, and organizations make smooth and successful organizational changes. There are a lot of different change management models out there, and many of them are fantastic. Some are really simple, some are very complicated. But there's lots out there to choose from. Again, this isn't about the best model, but one that works for you and one that you can use consistently over time. So if you're looking for a model for potentially your organization, or just to think through the processes of change, take a Google search of change management models. These are some of the more common ones. John Cotter's 8-step change model, the ADKAR change model, which stands for awareness, desire, knowledge, abilities, and reinforcements, the Satir change model, and Lewin's 3-step change model. Those are some pretty common ones that you might find. But like I said, what I'd like to do is rather than dig into one of those models, to just talk about change management as using an analogy. So Jonathan Haidt is a University of Virginia psychologist. He describes this tension between two minds in this way. So the first is that our emotional side is an elephant, and our rational side is the rider. And so perched on top of the elephant, the rider can hold the reins and seems to be the leader. But the rider's control is precarious because the rider is so tiny relative to the elephant. And so anytime that 6'10" elephant and rider disagree about which way to go, the rider's gonna lose, right? It's completely overmatched by the strength and size of an elephant. So we're kind of, if we think about this in terms of our own behavior, when we want to overeat, when we're procrastinating, skipping the gym, we're going to lose that battle. So let's look at each of these things that can help us determine human behavior. And a third that hasn't quite come up yet, which is the environment. Dr. Susan Mickey is a researcher at the University College London. She also created what she called the behavior change wheel to describe these behaviors, or how our behavior is influenced by our environment, by our capability, and by our opportunities that we have. So I'm going to use some of her language as well. Yes, so I'll use both of those terms when I'm talking about both the elephant, the rider, and the pathway, which is the environment. So when we think about the elephant represents two strong things. First is physical ability and emotion, including the strength of habit. So not only does the elephant have the physical strength and coordination to carry the rider, physical capability according to the behavior change wheel, Dr. Mickey's model, the elephant also represents emotions and instincts, which Dr. Mickey called automatic motivation. So these are desires, habits, and feelings, and they're all part of the elephant's strength. Sometimes these are the things that can help us with behavior change, and sometimes these are the things that can hinder behavior change. The next thing is the rider, and there's two aspects of behavior that come from the rider. So the first is brain potential, or Dr. Mickey calls this psychological capability. And the second is reasoning, or reflective motivation. So the rider needs to have the knowledge and thinking ability to work with the elephant. And this capability is necessary for the rider to be able to have the second, which is reasoning. And that means the ability to think about long-term goals and weigh information and consider alternatives that may result in a plan for a change of direction. So the rider's that rational side, that psychological capability, and deliberate motivation, so reasoning. And then the last piece that we haven't talked much about is the path, or the environment. It's the actual shape and characteristics of the path can influence the direction of the rider and the elephant. Dr. Mickey's model would call this physical opportunity. Do we have the opportunity to carry out this behavior change or this change? The path can also be shaped by the people around the rider and the elephant. So this is the social opportunity. Some actions are more socially acceptable than others, and the support or lack of it from the community can influence what people think and how people act. So if we imagine there are people either throwing logs in our pathway, or yelling at a rider and elephant to go away, or making sure the path is clear of obstacles and cheering the rider and elephant on, we kind of see that come up. So the weakness of the elephant is pretty clear. Our emotional and our instinctive sides can be lazy, skittish, sometimes looking for short-term gains. And change efforts can fail because of the elephant. Sometimes the rider can't keep the elephant on the road long enough to reach the destination, right? The elephant sees a patch of grass and wants to migrate over there to eat it. The elephant's desire for instant gratification is the opposite of the rider's strength, the ability to think long-term, to plan, and to think beyond the moment. But the elephant also has this amazing strength, and the rider has this crippling weakness. The elephant isn't always the bad guy. So emotion is the elephant's turf. Love, compassion, sympathy, loyalty, the fierce instinct to protect your kids, that's all the elephant. Your spine tingling when you have to stand up for yourself, that's the elephant. The elephant can get things done, and making change requires the energy and drive of the elephant. And the strength is the mirror image of the rider's weakness. The rider tends to overanalyze, overthink. Anyone who's watched someone take 20 minutes to decide what to eat on a menu can see this play out. And the path, finally, is crucial, right? It's hard to go against the grain of social norms, or easier to do things that are helpful when friends and family are supportive. If the stairs are dark and dangerous, people are going to take the elevator. If you've got one road blocked by traffic, you're going to take an alternate path. So these are all some of the things we can think about when we're managing change, is both the elephant, the emotional side, the rider, the rational side, and clearing the path to make sure it's easy to do the right thing or to do the change that we're looking at. So I hope there's a really nice video out there about the elephant, rider, and path analogy. It comes from Heath and Heath Switch, How to Change When Change is Hard. But I wanted just to use this as a metaphor for thinking about some of the changes that we're pursuing, some of the changes that we're hoping our staff and colleagues will adopt. And what are some of the things that you can do along the lines of motivating the elephant, directing the rider, and shaping the path? So what do you guys think? When we're thinking about managing change, of increasing behavior change among staff and colleagues, how can we appeal to that emotional side, the elephant? How can we be clear as riders potentially to create direction? And how can we clear a path so that it's easy to do this change?
Christina, this is John. I'm curious because I'm assuming, and I've heard this probably from other people, and I've dealt with this before. When you're implementing a change within an organization, a lot of time it's hard for staff and especially sometimes providers who have been doing it for a while to make that change. So where do you start in this kind of analogy to get them through that? Do you have to shape the path first, or do you have to appeal to their emotional side or their rational side? How do you kind of start progressing that change to help them understand that?
Yeah, I'm curious to hear what others think. So the question is about someone who, perhaps there's someone who's been doing the same thing for a very long time, and they're quite invested in that, they're comfortable in that particular way of doing it. We come along, hey, we've got a better way to do this and we'd like you to do it. What are some of the things that we can do to help with that behavior change? Anyone have ideas?
I'll start picking on people.
And
I'm looking at Ray right now since I see your picture. I mean, we've all been through this if we've managed any kind of change, that we've had someone kind of butt up against us. So even just share some of the things you've done to manage it, or just some of the things that barriers you've ran into that you could use advice in this analogy to help you through that process. Ray, I'll start with you.
I really think it starts with the writer having the great vision or the great aim to where we're going. And then motivating the elephant would be basically encouraging him that there's a better way, or there is a specific reward for going this new direction. And I think those things don't really take any personally, like we've seen in like our out of hospital cardiac arrest for Chelan and Douglas County, it was a tipping point, like a Malcolm Gladwell tipping point. Like all of a sudden we had a bunch of saves all at once that created a momentum for that elephant to keep on moving. And then the shaping the path, I feel like, is the easiest part, in which you identify everything that's in the way of to our destination, and just having the elephant help us remove those obstacles together, basically.
Yeah, that's great. That's kind of exactly the way I would think about it too, in terms of motivating the elephant or motivating behavior change in an individual. Different people respond to different things. Sometimes that's a patient story. Sometimes it's hard data. But what is it that will influence an individual's behavior? We need to understand that, and we can respond to that. And usually we want to get all of these pieces together, and they're part of our charter, or the business case that precedes it, about why are we trying to do this? Why is this important? How will this impact patient care? How will this impact the bottom line for our organization? So those can all be motivating depending on the audience or elephant we're speaking to. When it comes to directing the rider, I think about knowledge, skills, and abilities. If we want someone to do something differently, they need to feel confident that they can actually do that. So it could be education, it could be training, could be social opportunity, showing that your peers are doing this as well, can sort of help the rider to move towards what we want, what we're hoping to see in terms of change or behavior change. And then finally, shaping the path is just clearing those obstacles, like Ray said. What's getting in the way from a systems perspective? Do we have the resources to do this? Or is it some sort of policy barrier that's getting in the way? So making sure that we're keeping the opportunity available to people to do this easily, to make it the easy thing to do, are some of the things we want to be thinking about. Any other questions or comments about thinking about behavior change or managing change? We talked about today leadership, we talked about project management, and we talked about change management. We talked about those very, very big bucket items in a really short period of time. There's obviously a lot more that we could cover on those topics, but I hope that this it's potentially some review for a lot of you who are very experienced, who have a lot of knowledge in some of these areas. I hope it's potentially just a reminder and maybe gives you a few strategies to help integrate leadership, project management, and change management into your projects. With that, I don't have any more content for today. We're almost at close. I just want to see if there's any questions about anything else within the last four sessions. And if not, I've also got the evaluation, which I'll pull up as well for folks who don't have questions. But are there any questions about any of the content from the last 4 weeks?
Christina, this is John. I'm curious. I know a lot of the people on this call are either QI managers or kind of middle to upper management. How do you encourage people who learn these kind of skills to take it and either help apply it or educate their frontline staff or even their senior leadership? Because this can be really motivating, and then going back to either leadership or staff, sometimes it can be quickly deflating when they don't have the same education or expertise you have, and then they start throwing up barriers right away.
So the question is, how can you spread the quality improvement knowledge and approach? Is that kind of what you're asking?
Yeah, or even the quality improvement culture that they've learned.
Yeah, so there's lots written about how do you spread quality improvement culture. I would look at it again from the lens of the, I'll just back up, managing change. So when it comes to thinking about leadership above us, what motivates them? Is it, bottom line? Is it something else? Is it patient stories being the best in the business? Quality improvement can get us there, and there's lots written about what it can do. When it comes to ability, leaders don't have a lot of time potentially to do maybe 4 sessions of training or maybe full days of training, but there's little bits we can compile and share with them, and especially as we go through a project, we can bring them in, and that's the learning experience as well. When it comes to frontline staff, again, thinking about motivation, this is potentially appealing to ego. So this will be something you can add to your resume. This is something that will be valued by this organization, by other organizations. It will give you an opportunity to do your job and do your job better over time. And then making sure people do have the skills. I'm a big proponent of everyone in the organization should have some type of quality improvement training if that's the approach you're taking. And so, especially for frontline staff who are going to be using quality improvement on a regular basis, the tools and the techniques to get trained, and for leaders to support training for staff as well, and to have a basic level of understanding themselves. Hopefully that answers the question, John.
Yep, thank you.
Any other questions? And just a reminder, I've got the poll up too for today's session. We're also going to send out a final evaluation that sort of summarizes the 4 sessions to get your sense of that. We're always seeking to improve ourselves, so we take that feedback and we use it to adapt our next sessions and additional learning activities as we go. Okay, well, I have 9 o'clock. If there's no other questions, and hopefully you've had an opportunity to finish the evaluation, please feel free to sign off and continue with your day. Huge thanks for joining for the last 4 weeks, and hope this was valuable for you. Again, I'm available if you do have questions afterwards. Don't hesitate to reach out. Thanks.
This is North Valley Hospital, and we just want to say thank you, and we really enjoyed these 4 sessions.
Great. Thanks so much. Happy to hear that. Thanks, Ray.